Start by asking the patient to lie on their left side with their back aligned to the edge of the trolley. The knees should be drawn up to the chest and the neck flexed down. The lumbar spine should be exposed down to the natal cleft. Lumbar puncture may also be performed with the patient in the upright sitting position. While the upright seated position makes it easier to locate the midline, the lateral position is required if measurement of the opening pressure is intended. If measurement of the opening pressure is not intended, then either position may be used. Palpate the lumbar spine to find the L3-L4 or L4-L5 intervertebral space. These can be found using anatomical landmarks. Palpate the most superior point of each iliac crest. The line joining these 2 points is traditionally thought to cross the midline at the level of the L4 spinous process or the L4-L5 intervertebral space. Perform a full surgical-style hand washing and put on sterile gloves and a face mask. Eye protection may be worn. Prepare the exposed skin with chlorhexidine in alcohol, usually administered as a spray or swab stick. Allow to dry completely before proceeding. Apply a sterile fenestrated drape to the area, ensuring the L3-L4 and L4-L5 interspace is within the field. Infiltrate local anaesthetic into the skin and subcutaneous tissues with an orange or 25 gauge needle, and then into the deeper tissues with a larger needle, such as a blue 23 gauge needle. Allow at least 2 minutes for the anaesthetic to take effect. In this time, you can assemble the manometer and 3-way tap. There are 2 broad classes of spinal needle that may be used for diagnostic lumbar puncture: conventional and atraumatic. The conventional needle has a sharp, slanted tip and a distal tip opening. The atraumatic needle is blunt, closed at the tip, with a side port opening. Atraumatic needles are preferred because there is strong evidence that their use is associated with a lower rate of post-dural puncture headache and other complications. The atraumatic needle can be introduced through the same skin opening made for the local anaesthetic. A twisting technique is used along its axis to pierce the skin. Alternatively, an introducer needle may be used prior to insertion of the atraumatic needle to pierce the skin, as demonstrated here. Insert the introducer needle through the skin into the supraspinous ligament at the level of the L3-L4 or L4-L5 intervertebral space in the midline, in the trajectory intended for the spinal needle. The needle should be approximately 90 degrees to the skin surface and angled towards the patient's umbilicus. Then, holding the introducer needle steady, advance the spinal needle through the hollow of the introducer needle. Continue advancing the spinal needle through the interspinous ligament and the tougher ligamentum flavum. You should feel a gentle give or popping sensation as the needle pierces the dura and enters the subarachnoid space. Holding the needle firmly in one hand, withdraw the stylet from the needle and observe for CSF dripping from the end of the needle. When an opening pressure is needed, attach the manometer to the hub of the needle using the 3-way tap. Turn the tap to open the manometer and wait for the CSF to rise up the manometer and level off. This may take up to a minute or 2. 7 to 20 centimetres of water pressure is normal. Turn the 3-way tap to open the patient to the free end. Collect CSF sample in each of the sterile specimen bottles and grey fluoride oxalate tube for glucose. Ensure that all specimen bottles are labelled accurately and in the order they were collected. If you require a closing pressure, then at this point you can open the 3-way tap to the manometer again and wait for the CSF to level off, as before. Remove the manometer and 3-way tap from the hub of the needle and replace the stylet. Then withdraw the spinal needle and the introducer needle and apply a sterile dressing. Dispose of any sharps in a sharps bin.